So in this classes, any queries? Any queries from anyone? Any queries from anyone? Okay, okay.
Yes, ma'am. I did it now.
So I can see around 40-45 participants today. So like I have discussed about the fusional anomalies in the previous classes. So basically I'll just give a short like recapitulation of the previous classes also. So basically when we discuss, like when we find out, we basically first do an orthoptic evaluation to like judge what is the binocular vision anomaly of the patient. Okay, so based on the AC by A ratio, we normally decide like whether it is an insufficiency case or an excess case. Okay, the fusional anomalies, what we have discussed, it's about the convergence anomalies and the divergence anomalies. So any questions from any one of you? Any questions from anyone of you from convergence and divergence anomalies? Yes. Okay. So basically convergence and divergence anomalies, what we have to do, we have to do those battery of tests to diagnose if there is any convergence or a divergence anomaly. Okay. So those things we have already discussed in the previous classes. So if any one of you have any doubt in those things, we will discuss. Okay. Also, we discussed about some participants. Can you just switch off your audio? Yes, some of your audio is on, I think. Can you just switch off your audios? Okay. So fusional Vergence dysfunctions, what we have discussed before. Fusional Vergence dysfunction, it is a special case in where like all the Vergence as well as the Vergence also, they have dysfunctions in the Vergence parameters as well as the accommodative parameters also. So can any one of you, like whoever audio is on, can you switch it off, audio?
Sorry to interrupt, ma'am. Ma'am, you can mute. Post
Okay, wait a second.
उसमें कोई नहीं बोल रहा था
Not getting.
हम लोग भी लिख दिया था आपने हाँ मेरा भी डालो
Yes, I can mute it. But... Okay. So the fusional Vergence dysfunctions we have also discussed. We have also discussed about the basic exophoria and esophoria also. So basic exophoria and basic esophoria, what were there? The amount of exophoria was same for distance and near. For the basic exophoria and basic esophoria, the amount of esophoria was same for distance and near. So today we are going to start with the accommodative anomalies. So what are the parameters we measure in the orthoptic evaluation for determining accommodative anomalies? Yes, anyone would like to share? What are the parameters we measure for determining accommodative anomalies in an orthoptic evaluation? Yes.
Are you asking about the symptom and sign?
No, I'm asking how to determine, like you are performing an orthoptic evaluation, right? So you perform a battery of tests. So
Yes,
in those tests, how do you determine that the patient is having an accommodative anomaly? How you can determine that the patient is having an accommodative anomaly?
Ma'am, maybe patient has a blurring of vision if and the patient has already 6 vision and 6, but patient has a problem of blurring of vision, headache, yeah, ocular pain,
Okay.
and diplopia and many more.
Okay. So diplopia can be mainly due to those like Vergence anomalies, right? So the patient for a Vergence anomaly, what we have, the patient can complain of a diplopia at near, more at near. Okay. So while reading, the patient can face the difficulty. So most of the symptoms are almost similar to like in all these cases. Okay. So if a patient is having an accommodative anomaly, the patient will have headache, the patient will have asthmatic symptoms, the patient will have near vision difficulty. Okay. He can get a discomfort, a strain and fatigue on near what. Okay. Sometimes we find like the patients who are working in the IT sector, they cannot work for long hours. Okay. So those are the common difficulties they can get. So we need to test what is the patient's anomaly. So how to test? So what are the battery of tests what we perform in an orthoptic evaluation? So first we do a Watford dot test, then we do the Maddox dot test to find the foria. For the distance and near foria we measure by the Maddox dot test, right? So after we do the Maddox dot test, we do the NPC, the near point of convergence. Then we measure the near point of accommodation. Then what we do, we measure the amplitude of accommodation with the RAF ruler. So while measuring the amplitude of accommodation, we do it binocularly as well as monocularly also. Also amplitude of accommodation, what we are getting, we should correlate with the age of the patient, right? With the Hofstadter's formula, that is the 18.5 minus 0.3 into age. So if a 15-year-old child comes to your clinic, so what should be the amplitude of accommodation for the patient? Normal amplitude of accommodation for the patient, it is 18.5 minus 0.3 into age. So suppose the age is 15 years, so 0.3 into 15, it is 4.5, right? So 18.5 minus 4.5, that is 14.5 should be the wait 0.3 into age.
Sorry
Right?
to interrupt, ma'am.
Yes.
Ma'am,
Please tell me.
they are waiting, ma'am. Wait कर रहे हैं कुछ लोग join करने के लिए.
Okay, I'll just see. Wait. Yes, I've got. Yes. Okay, so how do you measure the amplitude of accommodation? So we need to compare with the Hofstadter's formula. So for a 15-year-old patient, so what should be the normal amplitude of accommodation for the patient? It is 18.5 minus 0.3 into age. That is a Hofstadter's formula. So 0.3 into 15, that is 4.5. So 18.5 minus 4.5 means it is a 14.5. So 14.5 diopter should be the normal amplitude of accommodation for a 15-year-old patient, right? So when you are measuring the amplitude of accommodation with a RAF ruler, if you find discrepancy in that, okay, means if you get a lesser amount of accommodation, amplitude of accommodation in the RAF ruler, that then it can strike in your mind that the patient might have an accommodative insufficiency, right? So also we measure the binocular accommodative amplitude of accommodation first, and then what we are doing, then we are measuring the amplitude of accommodation monocularly. Okay, so amplitude of accommodation is a very important test to diagnose whether the patient is having any accommodation problem or not. Okay, so if we get a binocular amplitude of accommodation that is normal, and monocular amplitude of accommodation, if it is abnormal than the corrective values, then there may be a chance of accommodative insufficiency. Okay, so amplitude of accommodation we have tested, and amplitude of accommodation also, suppose we are getting a lower amount of value, so always we try to we try to do it, we try to repeat it 3 times and see that whether the amplitude of accommodation is declining or not. Okay, so if a patient is having any accommodative insufficiency, so on trying for repeatedly, if we try, what will happen? The amplitude will decrease. Okay, so that will get. Okay, so the near point of accommodation will recede. The near point of accommodation will recede. Amplitude of accommodation will recede. Okay, and what else will get? We need to measure the what we need to measure? We need to measure the negative relative accommodation and the positive relative accommodation. So those tests, you any queries about negative relative accommodation and positive relative accommodation? Anyone have any queries regarding this? Negative relative, how to do a negative relative accommodation and a positive relative accommodation test? Okay, I'll just explain it in very shortly. I'll just explain it. So for measuring the NRA-PRA, first we'll do the negative relative accommodation test. So how do you do the negative relative accommodation test? You place a trial frame over the patient's eye. Okay, you give the patient a near target at 40 centimeter and you put plus lenses in plus 0.25 steps. Okay, so you see how much the patient can, what is the amount of accommodation the patient can relax. Okay, so that is your negative relative accommodation. So when you add those plus lenses, what is happening? When you add those plus lenses, it is basically it is relaxing your accommodation, right? And you are measuring the limit of NRA. So normal NRA value, what should be a normal NRA value? It is around plus 2.5 diopter. Okay, so if the negative relative accommodation, there is any discrepancy, definitely it may be an accommodative problem the patient is having. Okay, so negative relative accommodations, once we have done, so once we have measured the negative relative accommodation, then we'll measure the positive relative accommodation. How to measure the positive relative accommodation? You put minus lenses in minus 0.25 steps. You give the near target at 40 centimeter. The near reading book you can give at 40 centimeter and tell the patient when the patient gets the first sustained blur. So when the patient see the first sustained blur or reports the first sustained blur, then that is the end point of positive relative accommodation when you add those minus lenses. Okay, so you add those minus lenses is minus 0.25 steps. Suppose you are getting a PRA value of minus 3 diopter, that is quite normal. Minus 2.5 diopter to minus 3 diopter, that is quite normal. Okay, now let me tell you, if the patient is having any kind of accommodative insufficiency, what will be the patient's problem? The main patient's problem is the patient cannot stimulate accommodation to a proper to a normal level, right? So in a PRA value that shall be around minus 2.5 diopter, so you will get a lesser amount of PRA value when you are doing the PRA test. So you can get a minus 1.5, minus 2 or anything. So if you get a lesser PRA value, positive relative accommodation value, that means the patient somewhere the accommodation is lacking. Okay, so this is about the NRA-PRA test. Then what we do the dynamic retinoscopy. We need to do the dynamic retinoscopy for the patient. Okay, right? So dynamic retinoscopy, how would you do? You take a well-aligned retinoscope, put the MEM card, the MEM retinoscopy, you put the MEM card and ask the patient to read aloud those letters. Okay, you put the near light on, you do it from your normal working distance, and quickly what you do, quickly check you put the patient's distance correction over it. No working distance lens, nothing, just you put the patient's distance correction in the trial frame and quickly perform the dynamic retinoscopy, right? The dynamic retinoscopy, what is the normal value of dynamic retinoscopy? We get a normal lag of accommodation around plus 0.5 diopter to plus 0.75 diopter, right? So that is a normal lag of accommodation what we should get in a dynamic retinoscopy, right? So if you get a greater lag of accommodation, that is higher plus values, Okay, so normally you should get a plus 0.5 to plus 0.75. Anything above plus 0.75 is a higher lag of accommodation. Plus 1 diopter, plus 125 diopter, whatever it is a higher lag of accommodation. So if the patient is having an accommodative insufficiency, the MEM value, there will be a higher lag of accommodation in the MEM value, MEM value. Okay, so there will be a reduced near point of accommodation, receded amplitude of accommodation. There will be reduced PRA values, positive relative accommodation values. Okay, and there will be a higher lag of accommodation in the MEM retinoscopy, that is a dynamic retinoscopy. Okay, so these are the parameters. So you can also do a push-up test. You can also do a push-up test to measure the accommodation. No, sometimes we can do a push-up test. We can do a pull away method. Push-up test means the near target you are giving, innate target. You are telling the patient to look at those target and tell you when the letters becomes blur. So when the patient is having a first sustained blur, so that is the end point. Okay, so you hold the book like this. The patient is looking at the innate target, trying to read it, and you have to when the patient has to report to you when the patient is having a first sustained blur. So you slowly push the book towards his eyes. Okay, so at the point where the patient gets the first sustained blur, so that point you stop and then you measure it with the scale. So that is a push-up test. Then there is a pull away method. That means you are holding the book, that is blur, so you are pulling away the book till it gets clear. So you measure the distance like that. So there are lots and lots of ways of measuring accommodation. If you do not have a RAF ruler also, we can measure the near point of accommodation. We can do it with a near vision book. We can do it, right? So that is the thing. So you measure all these parameters. Also, what we do, the accommodative, we do the accommodative facility testing. So how to test the accommodative facility? Accommodative facility, how to test that? So what we do is like if the patient, whatever the NRA PRA value we are getting, okay, so first suppose we have got a plus 2.5 diopter, NRA value about plus 2.5 diopter, PRA you have got a minus 3 diopter. Okay, so definitely you can choose a flipper which is around plus minus 1.5. You can also choose a flipper which is a plus minus 2. Okay, so there are some some values that are normative values for all these flippers. Okay, suppose with a plus minus 1.5, the normal amount of cycles per minute should be around 10 to 12 cycles per minute. That should be normal for a patient. So now if you are when you are doing the accommodative facility testing of the patient, you find some 7 to 8 cycles per minute. So that means the number of cycles per minute has got reduced from the normative value. So that's how you check for the accommodative facility. Okay, so that is the thing. Any questions in this? Please to ask me if you have any questions. How to do the accommodative facility testing with the help of accommodative flippers? Any questions in this?
Ma'am, please repeat the push-up test.
Yes, push-up test means you are seeing what you are seeing. You are seeing how much the patient can accommodate. Okay, what is the ability of the patient to accommodate? Okay, so you're holding the book, okay, here at 40 centimeter. Fine, the patient can read it clearly. The innate target, the patient can read it clearly. For any measuring any accommodative parameters, what is the end point? The end point is the first sustained blur, right? For NRA PRA also, the first sustained blur, whenever the patient gets the first sustained blur, that means that is the end point of that. So push-up test, the patient is seeing the innate target clear. Now you're slowly moving the book towards his eyes. Okay, and tell the patient, can you read it? Tell me when you find those letters to be completely blurred. Okay, when the letters gets blurred, so you are pushing this near vision book towards his eyes. Okay, at one point of time the patient can see those letters blur. It will become blur. The patient will tell that it has become blur. Now you will tell the patient to blink and make it clear. If the patient cannot make it clear, that means that is the first sustained blur. Okay, so that is the first sustained blur. Okay, So that is what we noted down in the push-up test. So the distance you can measure it from the canthus. So suppose at 15 centimeter the patient has reported a first sustained blur. Fine. So that one you are measuring in the push-up test. And in the pull away method, the ulta thing you will do. That means you will from the first sustained blur you will move away to the point where the patient see it clear. So that's how you do all this test. Any questions? Any queries? Any questions from the NRA test? Because many students have joined, many people have joined, I can see. So if you have any questions, because you have not attended the previous lectures, so any questions regarding anything, please to ask me. How to do the NRA testing? Any questions regarding that? Please to ask me. Okay. So basically you will get a reduced amplitude of accommodation. You will get a reduced near point of accommodation. You will get a reduced PRA value in accommodative insufficiency. You will get a higher lag of accommodation in the dynamic retinoscopy. Also, you will find that the patient cannot clear the minus lens in the accommodative facility testing. That means with the accommodative flippers, suppose you are using a plus minus 1.5 flippers to test the accommodative facility. So you can use a Ward-Rock card. Okay, you can tell the patient to focus at the letters and tell that when you keep one lens in front of his eyes, the letters will become blurred. So he has to blink and make it clear. When the letter gets when the letters gets clear, immediately you flip it. Okay. So for flippers, what we do, we keep the plus lenses first and then the minus lenses. Okay. So plus 1.5 is in front of his eyes and he is having the Ward-Rock card in his hand. So first, when you put the flippers, the patient will have a blurred vision. Okay. Then the patient has to blink and make it clear. When it gets clear, you quickly flip it. Then the minus 1.5 comes in front of your eyes. He will also see the blur and he will try to make it clear. So a complete one cycle is that when the patient can clear both the plus lenses and the minus lenses. So basically before starting the accommodative facility testing, what you are doing, you have the stopwatch in your mobile to make it ready. So when you start the exercise, you start your stopwatch. Okay. So what will happen? When the patient, you started your stopwatch, when the patient tells clear, you flip it. Then the patient will again see blur with the minus lenses and again try to make it clear. And once it gets clear, again you flip it. So one complete cycle is once it clears the plus lenses and the minus lenses. Okay. So that is one complete cycle, right? So how many cycles in a minute a patient can complete, that you are going to test. Okay, suppose he has completed, he could complete 10 cycles in a minute's time. So once in the stopwatch, when it becomes 1 minute, you put the end the stopwatch and end the test. So that's what you report it, like how many cycles the patient can complete. 10 cycles, the patient can complete 4 cycles, 4.5 cycles, whatever it is, you record it. So you do the accommodative facility testing first binocularly, then you do it monocularly. Monocularly means you will both do it both for the right eye and the left eye. And again, we compare the results. We see that with how much ease the patient is clearing the plus and minus lenses in the accommodative flippers. If the patient can clear both plus and minus lenses with ease, that means the patient's accommodation is quite okay. The patient, there is no accommodative infacility. Okay, accommodative facility is proper. But if the patient cannot clear the minus lenses, that means the patient has difficulty in stimulating the accommodation. The patient has difficulty in stimulating the accommodation. That means he might have an accommodative insufficiency. Okay, so that is the case. If he cannot clear the plus lens properly, that means what is happening? The patient cannot relax the accommodation. Maybe he has stimulated the accommodation, but he cannot relax his accommodation. So in an accommodative insufficiency will get the patient, you can get the patient can find it very hard to clear the minus lens. So that will be the symptoms, that will be the signs for accommodative insufficiency. Okay. So is it clear to everyone? Any questions? Any questions, please to ask. Yes, any questions? Okay, so we'll move to accommodative excess now. In accommodative excess, what will be happening? The patient is accommodating more and more. The patient is accommodative more and more. So accommodative excess must be differentially diagnosed, means that must be separated, or we should be able to like diagnose accommodative excess properly, because it should not be confused with the accommodative spasm, okay, or a pseudomyopia case. So those are completely separate. Accommodative spasm means there is too much of accommodation, 100% accommodation the patient has, just think it that the patient has utilized 100% of his accommodation. That is accommodative spasm, and he cannot come back to normal. But accommodating excess is a different one. Why different one? Because the patient has accommodation, he has over accommodation, he is over accommodating, and he can also come back to normal easily. Okay, you need not to do so much of efforts. So in an accommodative excess, the symptoms will be similar to accommodative insufficiency. Okay, similar to this, that means those patient will be having asthenopic symptoms, headache, blurring of vision while reading, uh, difficult to perform distance and near work, all these sort of things the patient will be having. But when you check the patient's accommodation in your orthoptic evaluation test, you can find the difference. So what will be the first sign? There will be variable, static and subjective amplitude of accommodation. Okay, so amplitude of accommodation, what we are testing, sometimes you are getting about like you can get an excess amount of accommodation. Okay, suppose the required, the normative value the patient should have around 12 diopter accommodation. When you are testing the amplitude of accommodation, you are getting a 13 diopter, you are getting a 14 diopter accommodation. So the amplitude of accommodation will be at a higher stage. Okay, there will be fluctuating accommodation. What we will be getting? Okay, we will be getting a fluctuating accommodation. Okay, you will also get a, okay, so you will also get a, what will be having, you can find when you do a MEM retinoscopy, that is a dynamic retinoscopy. When we are doing quickly, when you're doing checking the dynamic retinoscopy, you can get a lead of accommodation. Lead of accommodation means the normal lag of accommodation is plus 0.5 to plus 0.75, right? So if you get a plus 0.25 or a 0 or somewhat in somewhere in minus, if you are getting, that is a lead of accommodation. So definitely in MEM retinoscopy you will get a lead of accommodation in accommodative excess. Okay, so amplitude of accommodation is on a higher stage. If you repeat the amplitude of accommodation in 1 or 2 to 3 times, you can find there is fluctuation of amplitude of accommodation. Okay, if you are testing the amplitude of accommodation monocularly, you can get a higher value. Okay, you will get a lead of accommodation in the dynamic retinoscopy value, right? And then when you are doing the NRAPRA testing, when you are doing in the negative relative accommodation, what you are measuring? You are measuring how much the patient can relax the accommodation. How you are doing it? You are putting, you are giving a like NA target at 40 centimeter for the patient to look, and the patient has to report the first sustained blur. You are putting plus lenses in 0.25 plus 0.25 steps, and the patient has to report when it gets blur, and the blur remains. That is the first sustained blur. So you will get a reduced NRA value. So normal NRA value is around plus 2.5 diopter. If you are getting a somewhere around plus 1.5 or a plus 2 diopter, that means the patient cannot relax the accommodation to a normal level. Okay, that means he cannot relax his accommodation. He has accommodation. Accommodation is there is greater amount of accommodation than required, and also he cannot reduce the, he cannot relax his accommodation. Okay, also if you are testing the PRA, okay, PRA normally we get around something around minus 2.5 to minus 3 diopter and all. If your refraction is correct, so around like that you should get. When you are doing the PRA testing, the positive relative accommodation testing, what we are getting when you are doing the positive relative accommodation testing, you are getting a higher minus value. That means the PRA value is higher. That means you can get, suppose around minus minus 4 diopter, minus 5 diopter, minus 6 diopter of PRA. You get confused. You get confused, okay, right? So how why? Because you are getting a very higher amount of PRA value. Also, when you do the accommodative facility testing, you find the patient find it very hard to clear the plus lenses. Okay, you have selected the accommodative flipper. When you are putting the plus lenses, patient is taking much time to clear the plus lenses than the minus lenses. Any questions from this part? Please to ask me. Yes.
Ma'am, what is the normal value of PRA?
See, for NRA, we have a normative value that is around plus 2.5 diopter. For PRA, we cannot tell the normal value because the PRA we correlate with the negative fusional Vergence value. We correlate with the the step Vergence testing value, and then we can tell. So there is no normal value of PRA, but still you can think that will be somewhere around minus 2.5 to minus 3. That is okay. Anything less than minus 2.5, that is not normal. Anything higher than minus 3, 3.5, that is also abnormal. Okay. So basically all these binocular vision parameters we correlate with, you correlate with the other values. Okay. So even NRA PRA is also an indirect measurement of the Vergence. So in my previous lectures also I discussed that whenever you are, suppose you have given a near target for the patient to read, first the patient will utilize his Vergence reserve. He will utilize first his positive fusional Vergence reserve. Then only his accommodation reserves will be active. Once the fusional Vergence reserve will get exhausted, then he will use his accommodative abilities to clear the target. That is the thing. So all this convergence and accommodation act together, and it is very hard to separate them. You cannot separate them. So we basically correlate these many values to find it whether it is a Vergence anomaly or an accommodation anomaly. That is the thing. Okay. So this is about accommodative excess. Now accommodative infacility. What is accommodative infacility? When you are doing the accommodative facility testing with the accommodative flippers, so suppose you have got a plus 2.5 in the NRA, minus 3 in the PRA value. So you can take a plus minus 2 flipper. You can choose a plus minus 2 flipper. You cannot choose any flipper value which is higher than the NRA PRA value. Why? Because if you're choosing the flipper, the accommodative flipper value higher than the NRA PRA value, the patient will not be able to clear the accommodative flippers. So accommodative facility testing we are going to do. Once you select the accommodative flippers, the power of the accommodative flipper, then you do the accommodative facility testing. Okay. Same way you give the Wardrock card for the patient. It is an innate target over there. Okay. Patient will see that target, and patient has to, when you put that accommodative flipper in front of his eyes, he will find that blurred. So once he find it blur, he has to make it clear by blinking. Once he can make it clear, again you will flip it. Okay. So in case of accommodative infacility, what is the thing? You will find that the patient will find hard to clear both the plus and minus lenses. That will be his problem. That means the patient might have good accommodation. Okay, he might sustain his accommodation for a longer time also, but he is finding it hard to clear the plus and minus lenses. Means he cannot clear the like the accommodative facility is lacking. Okay, so my accommodation should be dynamic, right? When I'm looking at distance, I should be able to see it clear. Suddenly, if I have to look at near, I should be able to make it clear, right? So that is your accommodative. Means you should be able to relax your accommodation properly. Also, you should be able to stimulate your accommodation properly. So that is basically your accommodative facility, what we are testing through the accommodative flippers. Okay, so in accommodative infacility, basically we'll get that the patient find it difficult to clear the plus and minus lenses both for the accommodative flippers. Now coming to ill sustained accommodation, there is a term called ill sustained accommodation. That means the patient can have normal amount of accommodation. Okay, when I'm testing, suppose you need to have a 12 diopter accommodation in the amplitude of accommodation, means what we measure with the RAF ruler, the amplitude of accommodation. He should have 12 diopter. If you are testing the amplitude of accommodation, you have got a 12 diopter, 12.5 diopter, 11.5 diopter, whatever. So he is having a normal accommodation, but he cannot sustain the accommodation for a long. That is the ill sustained accommodation. Okay, ill sustained accommodation. First time when you are testing the accommodation, suppose you have got 12 diopter. Second time when you are testing, you will get a 0.5 diopter to 1 diopter less. You have got, suppose from 12 diopter first time you have got, then you have got 11 diopters. Third time when you are doing, you are getting a 10 diopter. Fourth time if you are doing, you might get a 9.5 diopter. So that is an ill sustained accommodation. मतलब मुझे accommodation है, लेकिन मैं वो accommodation को मतलब sustain नहीं कर पाती. That is the main thing. I cannot sustain the accommodation for a longer duration. I have accommodation, but I cannot sustain it for longer duration. That is the ill sustained accommodation. That is the case. So basically in accommodation anomalies, what we are doing, we should correct the refractive error. Definitely we can give the plus lens therapy if the patient cannot relax the accommodation. We can give the prism therapy, we can give the occlusion therapy, we can give vision therapy, and definitely we do not go with the surgery. It is written, but we do not go with the surgery. Optical correction means we should give a hyperopic patient, okay, having problem in accommodation, you should give the cycloplegic, you should do a cycloplegic. Accordingly, you will try to give full plus. Okay, so depending on the phoria status, if the patient is having exophoria, patient is hyper